Good morning, everyone. I'll be presenting my thesis topic on incidence and predictive factors of recompensation in children with decompensated cirrhosis as per Baveno 7 criteria. My guide was Dr. Vikrant Sood. So, as we know, decompensated cirrhosis is predominantly defined in literature as a unidirectional phenomena and an irreversible phenomena. But there were initial studies which proved that decompensation can be reversed, and the initial studies showed a vague incidence of 8.2% to 65.5%. However, post the Baveno 7 consensus in 2022, there were multiple studies which came up and on the based on Baveno 7 criteria of recompensation, whereby the recompensation incidence ranged from 7% to 63.4%. So what is recompensation as per Baveno 7 consensus? So recompensation is predominantly defined in patients with decompensated cirrhosis with first most important criteria is suppression of primary etiology with resolution of ascites, HE, and bleed, and normalization of liver function for a consolidated period of 12 months. And patients should be off diuretics or not on HE prophylaxis, and non-selective beta blockers, however, is allowed to label a patient as recompensation of cirrhosis. There were also studies on how the recompensation phenomena happens. So there were multiple biomarkers which were detected, which included interleukin 1 alpha, interleukin 1 beta, which persisted and predicted the risk of fatal ACLF. Hence, there was certain kind of evidence that inflammation and abnormal intestinal permeability as a potential target for future therapies to facilitate and maintain recompensation. So based on this lacunae, as there was no standardized, there were limited prospective data which defined recompensation, and there is till date no pediatric literature available on recompensation of liver disease. Based on this lacunae, we aim to address this issue. The study hypothesis was recompensation is a common phenomena in children with decompensated cirrhosis cirrhosis, but has never been systematically studied. Our primary aim was to evaluate the incidence and predictive factors of recompensation in pediatric subjects with decompensated cirrhosis as per Baveno 7 criteria. Primary objective was to determine the incidence. Secondary objective include to evaluate the predictive factors of recompensation in pediatric DCLD subjects, to investigate the systemic and intestinal inflammatory markers for predicting recompensation in children, and to assess incidence of decompensation in patients with recompensation. This is predominantly an ambispective observational study, whereby the study limb from retrospective data included from January 2014 to December 22, and prospective limb from January 23 to December 24. We included all the patients less than 18 years of age at presentation with decompensated cirrhosis at baseline, and which fulfilled the recompensation criteria, which I have previously described as per Baveno 7. We excluded all the patients who refused consent, patients with liver cancer or other active malignancy with incomplete data, and any significant extrahepatic disease. Due ethical clearance was taken. So we defined cirrhosis based on liver histology finding with F4 fibrosis as per Ishaq system. In cases where biopsy was not feasible, radiological findings of an irregular nodular liver with or without left caudate lobe enlargement was taken. Decompensation parameters were taken as per standard guidelines, which included ascites, HE, variceal bleed, and re-decompensation was defined as new onset decompensating event in a patient who had previously achieved recompensation. So as I previously described, I'll re-describe the recompensation criteria should fulfill all three of the following. One, sustained cure and suppression or removal of the underlying etiology of cirrhosis, resolution of ascites and HE after discontinuation of diuretics and prophylactic therapy, as well as the absence of variceal bleed for 12 months, and sustained improvement of biochemical liver function as assessed by serum albumin, bilirubin, and INR. So this was my study design, whereby all the DCLD patients at baseline was taken. Treatment was initiated. Sustained resolution was documented for a period of 12 months, and post that patients were classified into two groups. One, those who recompensated, those who continued to have persistent decompensation. So baseline parameters, demographic profile, anthropometry, imaging, biochemical, and severity scores were calculated. We also looked at inflammatory biomarkers. Predominantly systemic inflammation was seen by interleukin 6, TNF alpha, interleukin 1 beta, and intestinal inflammation was seen for stool cytokines, interleukin 6, TNF alpha, interleukin 1 beta, interleukin 10. Standard statistical analysis and tools were applied. Coming to results, this was our gross etiological distribution, whereby AIH and Wilson's contributed to the major chunk of the etiology. So since these were the two, so I have analyzed the Wilson's and AIH part. So I'll be describing first the Wilson cohort. So total number of Wilson's admitted were in ILBS from 2014 to 24 were 228. Wilson's disease which fulfilled which had decompensation at baseline were 168, and they were looked for eligibility, and 79 patients after applying the exclusion criteria, 79 patients were evaluated in final analysis. So overall recompensation rate, including death and LT, was 64.2%. And the baseline comparison between recompensation versus no recompensation group were similar in terms of basic demographics. Age at onset was also similar without any statistical difference, which was 8.8 in recompensation and 11 years in no recompensation. However, the children who recompensated had a trend towards...
Sorry, go back to previous slide.
Yes, sir.
Previous slide.
Yes, sir.
So why did you exclude these patients?
Okay. Sir, these were excluded. 21 patients were lost to follow-up. 8 died before less than 1 year. 22 died in less than 1 year period. 36 had incomplete data, and 2 have not completed 1 year of follow-up.
Total proportion of patients out of 228, you have 79,
Yes, sir.
and
60 were, sir, compensated CLD, so they were excluded at the starting only because we have taken decompensated cirrhosis for the Baveno 7 thing. So 60 were included at initial and 168 were left. Few were excluded because of these reasons.
okay.
So coming back to baseline parameters, age at onset, age at diagnosis, type of recompensation was similar in both the groups. However, there were certain differences based on lab parameters as to that ALT was slightly higher in the no recompensated group, and TLC count was slightly lower in no recompensation group, and platelet count was also lower in the no recompensation group. The severity score were similar and statistically non-significant in the both the groups. However, BMI and weight score and other anthropometric parameters were also non-significant. However, liver stiffness was slightly more in the no recompensation group. The other parameters, the no recompensation group had higher incidence of bleed, which was also statistically significant. So this we'll also looked at the temporal evolution since this is a long-term study and a lot of longitudinal data has come into play. So this was the temporal evolution of the key parameters of recompensation and no recompensation. We can see bilirubin, INR, albumin trend, and AST trend, and we can see the significant difference between the recompensated versus no recompensation group. We also looked at time to recompensation of each symptom. HE and bleed were earliest to resolve, followed by ascites, jaundice, coagulopathy, and albumin was the last to resolve. So we also looked at predictive factors for recompensation. So lower ALT count, lower uric acid, lower liver stiffness, lower USG size, and lower BMI predicted were significant in recompensator group. However, we could not perform multivariate analysis due to small numbers in no recompensation group. There were almost 12.2% patients who had re-decompensation as we had defined, and primarily these were due to poor compliance in Wilson's group because of the stoppage of drug. They had recurrence of the decompensating event. Then we also looked at the cytokine analysis in this Wilson's group to understand the pathophysiological basis of the recompensation. So as we can see in this group, where interleukin 10 was higher in the plasma group, and interleukin 6 was more in the stool interleukins were more in the recompensation group. So I'll explain this with this radar plot. Just to orient you, the center plot, the center of the graph to the periphery includes the degree of the concentration of the cytokines. More they move towards the periphery, more is the cytokine level. And we can clearly see in this orange, this is for the stool sample. In this orange, there is selective increase in certain cytokines. So in the Wilson's cohort, interleukin 6 was statistically significant in the stool sample, and in the plasma, interleukin 10 was statistically significant in the recompensator. So this implies that in plasma, since interleukin 10 is known as is a known anti-inflammatory cytokine, so this might predict the recompensation phenomena in those who recompensated. And interleukin 6 in the stool, since interleukin 6 is a known anti-inflammatory in plasma, but however in gut epithelium, it helps in restricting the injury. So coming to the second cohort of AIH, total admitted patient with AIH was 258. However, 102 were excluded because they were asymptomatic or compensated. ALF and overlap were also excluded from the analysis, and the children who had decompensation were only included, so they were 114, and those after applying the standard exclusion criteria, 78 were evaluated in the final analysis. In the recompensated cohort, 62.7% had recompensation. The baseline characteristics was similar in most of the aspects between recompensation and no recompensation group. However, ascites was statistically significant and more in the no recompensation group. The lab parameters, AST was higher in the no recompensation, in the recompensators. Rest lab parameters were not significant. Similarly, as in the Wilson's cohort, the spleen size was more in no recompensation group, and weight and height was more in the no recompensation group. Rest parameters were similar in both the groups. So as in the Wilson's group I had described, this is the temporal evolution of the key parameters, which includes bilirubin, INR, and ALT and albumin, and we can see the significant difference between the two groups. In this also, ascites followed by jaundice, followed by albumin was last to improve in the recompensation group. We also looked at the predictive factors of recompensation in the AIH cohort. So weight, height, ascites, USG liver size, and spleen size were predictive factors in the univariate analysis, and USG spleen size at the baseline was the independent factor for the predicting recompensation. And in this also 12.7% had recompensation, and in this most common cause was predominantly the disease flare and poor compliance. The cytokine pattern in AIH was slightly different from the Wilson's, as to that interleukin 1 beta was more in the stool sample, and interleukin 10 was elevated, was more in the stool samples of the recompensator, and interleukin 6 was less in the in plasma in recompensators. Explaining in the similar way, the stool cytokine, as we can see in this radar plot, that interleukin 10 was more, interleukin 1 beta was more in the recompensator, and interleukin 6 was less in recompensator. So comparing the, for better clarity, comparing the cytokine findings between AIH and Wilson's, as we can see the pattern of cytokine is different in both the disease. This primarily is because of the different pathophysiology. Since autoimmune is a pathological increase in the inflammation, and however Wilson is due to the copper toxicity mediated injury. So hence we can see that in autoimmune, as per my findings, the lower plasma interleukin 6 indicates reduced systemic inflammation and favors autoimmunity control. Higher stool interleukin 10 indicates enhanced mucosal tolerance, which suppresses autoimmune signaling, and higher stool interleukin 1 beta, which localize the gut localized response. However, in Wilson's, stool interleukin 6 indicates localized immune response and buffers systemic inflammation, and plasma interleukin 10 buffers the copper-induced damage. So this gives a very important insight that the pathophysiology and cytokine role change as per the compartment, whether it is the gut or a systemic compartment. This is the comparison between the two etiologies, and we can see Wilson's had slightly better recompensation rate as compared to the AIH. And this could be because of the different pathophysiology. This is the data from the adult recompensation, where they had seen at the pathological determinant, and more the single etiology and definitive treatment is available, better is the recompensation rate. As the etiology becomes more and more complex and pathophysiology is less elucidated, the recompensation rate falls. So strength of this study is first, this is the first pediatric study with large, well-defined etiological cohorts with standardized Baveno 7 aligned outcome and with a detailed longitudinal prospective follow-up with exploratory cytokine seen, which gives insight into gut-liver immune axis. And however, this suffers from few limitations, like this is a single center design. It has a potential bias might be there. Treatment heterogeneity may have altered the result. A small number of non-recompensator, especially in Wilson's disease, might have limited the power. The cytokine analysis, which was done as an exploratory thing, and there was limited sample size and no direct HVPG correlation was done. So there might be underestimation of portal hypertension. So to conclude, recompensation is common and meaningful in pediatric cirrhosis. Early therapy plus non-invasive markers like spleen size, stiffness, and platelets may aid risk stratification, and targeted adherence strategies and gut-liver immune pathway insights may consolidate recovery. And future studies are required for the multi-center validation and biomarkers-driven studies. Thank you.
Thank you, Anmol. And sir, based on this was actually a very simple study. We all knew that if you have a more severe portal hypertension, you have higher platelets, you have lesser stiffness, you are bound to do better compared to those patients who do not have these things. So we knew what would be the predictive factors beforehand. That is what has been our clinical experience. But the important thing was that we could standardize it and we could say that majority of our Wilson's and autoimmune patients still do well. Though we had excluded those patients who died early or who required liver transplantation. But if you can pick up these treatable etiologies early, not all patients can survive without a liver transplant. But if you can pick up these cases early, then you can always give them a good outcome. But it's only 2/3. I'm not saying we had a very good outcome or we are saving 80, 90, 100% of these cases, but majority of the patients still did well on treatment therapies. And about the stool and plasma cytokine, these are less number of patients. We had tried to postulate what different cytokine levels in stool and plasma mean actually, but even our knowledge is limited, and I think we need larger studies on this aspect.
Very good. The Anmol, you did well. I have few comments. One, briefly, you should combine the two, Wilson and them, and then see what are the predictive factors in the two groups rather than separate them. Separating is okay, but total group also. And also the effect of steroids or depend should be separately analyzed. Otherwise, it's a very good data. Although I'm not convinced on the cytokines, because even in autoimmune, IL-6 is known to be quite high. But it is a good data. Any other comments or so?
Vikrant, so maybe I missed the data, but still your comment, if you're excluding early deaths and liver transplantation from any data set where you're going to say that patients are recompensating, I don't think that data will hold any ground. Because then basically you're saying as simple as it is that you're playing with patients' life. Because you're just pushing them towards, you don't know, and then you're just pushing them towards where they actually can have a curative treatment, a long-term good quality of life treatment, which is being withheld in order to see something, and then you're not actually analyzing that's in that data. How can you justify that?
Sir, can I answer? Thank you, sir, for your comment. Sir, we had analyzed the death and LT. This overall recompensation rate is including the death and LT, which is 62.7% in the AIH group. And for the Wilson's cohort also.
But if you're saying recompensation rate, which include death and LT,
yes, sir.
Then what does that mean?
Sir, this.
You know what you're saying?
Yes, sir. Yes, sir.
So you are
Recompensation.
including recompensation, which includes death and NLT.
So that is why our proportion is down to 64%. Otherwise, it
Sir,
was much
we
higher.
have calculated two
Yes.
percentages. This is the overall recompensation rate one. And this, with this graph, you can see the just in with the recompensation rate, which is 88.6% if we exclude death and LT, and 69.2% if we exclude who have proper 1 year of follow-up. Regarding the second comment, regarding the death and LT, sir, we are also analyzing the excluded patient as you have suggested, with the intention to treat analysis, competing risk analysis. This work is underway. We'll be
That's the
evaluating.
most important thing. It's not underway. You should have presented data. If you're going to present any longitudinal data, and if you don't present intention to treat analysis, the whole story is over there itself.
Sir,
You know, this whole data become biased.
sir,
You know, to start with, it become biased. Because if you take 100 patients and you're not doing an intention to treat analysis, and then you just say that recompensation, which includes death and liver transplant as well, then how does that data validate?
I can
You
answer.
know,
Let them reply.
Yes.
Reply.
Sir, Baveno 7 means if you have to apply that criteria, you need to have 1 year of prospective follow. You cannot include any patient who does not have 1 year of follow. So our study was practically for Baveno 7. So if the patient who had died of liver transplant, we cannot include them in the analysis for recompensation versus no recompensation. That is my problem. But definitely, as you have said, that we should include those patients who died early or who had undergone a liver transplantation in that. Yes.
So that is just misinterpreting
Raki, your
Baveno
comments?
7, because then they are
They
all
start from recompensation. They're not starting the natural history of the disease.
Yes.
That's a different concept. But your point is well taken, Raki. Any comments? You have your mic next to you. Just start that mic.
Yeah, this data is interesting, but what we will understand from this is not actually the messages are not coming out. Because when you're saying you're doing a 1 year analysis on a disease which changes, there will be patients who will get further decompensations, there will be patients who will recompensate. So, overall, when you take this set of patients, you have to take everything and then you do competing risk for
Yes.
adjusting for patients. Like what you're saying is absolutely right, but that has to be adjusted in a competing risk. And this data should come out as a time to event analysis, because in the natural
I
history,
agree. Ma'am, that,
and interventions will also make a lot of difference.
ma'am, I
So that
definitely
is
agree
one
that.
thing, because
Yeah.
when you show that table, no, see, go to the table of recompens in Wilson's. So the message which is coming out is like 90%. Okay, you're showing overall, but analysis, just go back. The 9
Yeah.
patients, just go. 9 only did not recompensate in Wilson's. So that
Yes,
is the
ma'am, that
message
is,
which
yeah.
comes out.
So, ma'am, actually, that is the limitation. This is not a natural history study of disease. This was typical. I definitely agree, because we are
This data is
confounding our
very good,
results.
but you can present it
Yes,
in
ma'am.
a
We are
more robust
yeah,
form
we are
with the
confounding our own
analysis.
results. I agree with
Yeah.
that, because we are excluding the sicker patients who have already died, who have already transplanted early. That is the main
And my
issue with
second
this.
point was on the cytokines. When you took these patients of autoimmune, so were they on corticosteroids
No,
at the
ma'am.
time of analysis?
No, ma'am.
No, when were these cytokines picked up?
This is at the
Baseline, ma'am.
baseline
Yes.
cytokines when they presented to us in a
So
decompensation.
what was their systemic inflammation profile? Was it correlating with the stool cytokine? Because that data is very interesting, but that has not been presented to where
Could
for us
only
to
check for
understand.
CRP and yes.
Procalcitonin, ma'am, it was similar in.
So something should be shown with respect to what does it signify? The gut inflammation, what does it signify? So
Okay.
those were my 2 points.
One of the major things what Vinay and Raki is saying, we should have total patients, how many died for reasons, and then those whom you define of the total, you have just picked up the recompensation. I think intention to treat is important,
Yes.
and also the influence of therapies and what therapies were given. Anyway, Anmol, in the interest of time, no more comments. Thank you. Good.
Thank you, sir.
We have a second presentation.
Yes.
And I think the operations people also want to say something. Okay. But I like the graphs Anmol made. There's nice graphs, the radar especially. Good graphs.
So ILBS is starting with the e-newsletter, and we request each one of you, students, faculty, and everybody to share their 3 months achievements, awards, latest techniques you have developed, or anything you would like to share for the e-newsletter, your poems, your jokes. They are invited. And it will be really, I'll highly appreciate if you can send it by 20th of February. And this will be released quarterly. And this will be the volume 1, the inaugural e-newsletter. Thank you.
Very good initiative. Thank you, Sukriti. Yeah, please proceed with it.
Good morning, everyone. I'm Dr. Nidhi Singh from Department of Anesthesia. My research topic is assessment of autonomic function and its impact on the liver transplant recipients with chronic liver disease. It is a prospective observational study. So, chronic liver disease represents a growing global health burden due to increasing alcohol use and metabolic liver disease. India also contributes significantly to CLD-related mortality with increasing prevalence of metabolic, non-alcoholic, and alcohol-related liver disease. CLD is a systemic disorder affecting multiple organ systems, including autonomic nervous system. So the prevalence of autonomic dysfunction in CLD patients is 30 to 70% in various studies. And this prevalence increases with the severity of liver disease, correlates well with MED score and Child-Pugh classes. The autonomic nervous system regulates involuntary functions such as cardiovascular, gastrointestinal, respiratory, temperature, and metabolic functions. So autonomic dysfunction is impaired autonomic nervous system regulation leading to abnormal heart rate and blood pressure response to the stress. Autonomic dysfunction is characterized by cardiovascular instability, fatigue and cognitive impairment, gastrointestinal dysmotility, urinary incontinence. Autonomic dysfunction causes impaired circulatory adaptation during physiological stress, and it leads to hemodynamic instability in cirrhotic patients, especially in cases of stress like surgery. So autonomic dysfunction can be, on the basis of etiology, it can be 2 types. One is primary, where an autonomic dysfunction is a part of disease itself. For example, pure autonomic failure, Parkinson's disease, and familial dysautonomia. And it could be secondary because of external factor which can lead to autonomic dysfunction. For example, diabetes, amyloidosis, autoimmune disease, nutritional deficiency, and chronic illness like chronic liver disease and chronic kidney disease. So there are 3 stages of autonomic dysfunction. First is parasympathetic dysfunction. It involves only parasympathetic nervous system. It is earliest marker of autonomic neuropathy in cirrhotic patients. Second one is sympathetic dysfunction. It involves sympathetic nervous system. In advanced stage, one compensatory mechanism are exhausted. Sympathetic system also involved. And third one is mixed autonomic dysfunction, which includes concurrent impairment of both sympathetic and parasympathetic system. Now coming to pathophysiology, portal hypertension and cirrhotic portal hypertension leads to release of lots of vasodilators, for example, nitric oxide, carbon monoxide, endotoxin, cytokines, which leads to decrease in mean arterial pressure and systemic vascular resistance. This leads to activation of RAS system and persistent stimulation of RAS system causes hyperdynamic circulation, which is the compensation of liver patients to maintain cardiac output and ejection fraction. But persistent stimulation of this RAS system can cause downregulation of cardiac beta receptor and decrease peripheral density and function of adrenergic receptor during orthostatism. Plus, angiotensin 2 is directly inhibitor of vagus nerve. Apart from this, direct neurotoxic effect of alcohol, some viral proteins and bacterial toxin causes nerve damage. Plus, there is nutritional deficiency like vitamin B12 deficiency. Both combined toxic and nutritional factor lead to gradual decline in nerve function. So research gap, available literature observed its effect of autonomic dysfunction on long-term mortality and quality of life in non-surgical settings. there is scarcity of studies focusing on the effect of autonomic dysfunction on cardiovascular instability in liver transplant recipients. Correlation between preoperative autonomic dysfunction and immediate postoperative morbidity, such as long length of ICU stay and vasopressure weaning, remains largely unassessed. And specifically in this disease, they did not excluded diabetic patient, which is a common cause of autonomic dysfunction. So it has been studied since decades. Early study by in 2003 by Bajaj et al. And Perez et al. They reported autonomic dysfunction prevalence rate from 44 and 60%, while Bajaj et al. Focused on cirrhotic patient and noted higher prevalence in child class C. Perez et al. Identified a significant link between autonomic dysfunction and hemodynamic instability as low systemic vascular resistance and during the reperfusion phase of liver transplant surgery. So Bajaj et al. Focus on cirrhotic patient in non-surgical setting, and this Perez et al. They have emphasized especially in liver transplant recipients. In a recent study by Bhatti et al., 32 liver transplant recipients were evaluated for autonomic function, and they found a prevalence of 71.9% and autonomic dysfunction associated with prolonged hospital stay. So our objective and hypothesis is we hypothesize that liver transplant recipient with autonomic dysfunction have poorer perioperative outcome compared with those without autonomic dysfunction. And our primary objective was to determine the prevalence of autonomic dysfunction in the liver transplant recipients. And secondary objectives were to correlate the severity of autonomic dysfunction with MELD score and child class, to compare intraoperative hemodynamic instability between both groups, to compare total vasopressor requirement, both dose and duration between both groups, and to compare ICU length of stay, hospital length of stay, and 28-day mortality between two groups. So this study was a prospective observational study conducted in Department of Organ Transplant Anesthesia and Critical Care in Institute of Liver and Biliary Science, New Delhi, after approval of Institutional Ethics Committee. We included patient aged under 18 to 65 year coming for liver transplant, and we excluded acute liver failure and patient on acute and chronic liver failure because they were unable to perform the test, which I will describe later. And patient on heart rate lowering drug like beta blockers, calcium channel blockers. Patient who has pre-existing cause of autonomic neuropathy like diabetes mellitus, HIV, or autoimmune disease like SLE and rheumatoid arthritis. Our sample size was calculated based on Arora et al., who reported the proportion of subject with autonomic dysfunction as 71% in cirrhotic patient. And based on this formula, our proposed sample size was 80. So there are 5 different tests to assess autonomic dysfunction. 3 parasympathetic tests and 2 sympathetic tests. I will explain one by one. So for parasympathetic control test, the first one is deep breathing test. The patient is asked to perform 6 deep breaths in 1 minute, 5 seconds of inspiration and 5 seconds of expiration for 1 minute. The result is the mean difference between highest and lowest heart rate, which is calculated by RR interval across the whole 6 cycles and expressed in beats per minute. So normal value is 15, more than 15 beats per minute. Borderline is 11 to 14 beats per minute, and abnormal is equal or less than 10 beats per minute. So this is for first cycle. Inspiration and in inspiration, we have calculated maximum heart rate, which is 75 per minute, and during the expiration, we have calculated minimum heart rate, which came 50 per minute. So this is only for 1 cycle. So for 6 cycle, we have calculated maximum heart rate and minimum heart rate, and the mean of maximum heart rate was subtracted by minimum heart rate. So for this patient, mean maximum heart rate was 73 and minimum heart rate was 55, and the result came 80. So this is normal for this patient. Now second one is Valsalva maneuver. The patient was asked to maintain end expiratory pressure of 40 mmHg for 15 seconds, and the result came as Valsalva ratio, which is the largest RR interval after the Valsalva strain and the smallest RR interval during the strain. Normal values are ratio more than 1.21, borderline is 1.11 to 1.21, and abnormal uh, equal or less than 1.1. So we used this manometer to check the pressure of 40 mmHg with this connecting tube, and here is syringe is connected. So patient have to blow in this tubing, and pressure is seen in this manometer. So here the patient is performing this Valsalva maneuver. The third one is heart rate response to stand up, which is also known as 30:15 ratio. The patient was made to stand from a lying position, and the result is the 30:15 ratio. The largest interval, RR interval, around 30th beat, and smallest RR interval around 15th heartbeat after standing. So its ratio was calculated. Normal is more equal and more than 1.04. Borderline is 1.01 to 1.03, and abnormal is equal or less than 1. So in this ECG, after standing, we calculated at 15th beat a minimum RR interval. It is expressed in time duration. So it is 0.8 second. And at the 30th beat, we calculated RR interval, which is 0.82 second, and ratio came as 1.02. So this is the borderline. Now next test for sympathetic control, also known as BP test, blood pressure response to for standing. So systolic blood pressure was measured while the patient was lying quietly and after 3 minutes of standing. So normal is equal or less than 10 mmHg, borderline is 11 to 29, and abnormal is equal or more than 30 mmHg. Second test for sympathetic control is blood pressure response for sustained hand grip. The patient is asked to maintain 30% of their maximum isometric tension for 3 minutes. Diastolic blood pressure was measured on the non-dominant hand arm in 30 seconds before and at the end of the effort. The result is rise in diastolic blood pressure. So normal rise should be equal or more than 16 mmHg, borderline is 11 to 15, and abnormal less than or equal 10 mmHg. So first we have calculated the maximum tension patient can generate, and we calculated 30% of it and asked the patient to maintain 30% of maximum tension for 3 minutes in with dominating hand, and we calculated blood pressure in non-dominating hand. So on the basis of these 5 tests, our patient were divided in 2 groups. Group AD when patient diagnosed with autonomic dysfunction, and group non-AD patients without evidence of autonomic dysfunction. With all these 5 tests, severity total of these 5 tests which I have discussed, severity of autonomic dysfunction was graded. So early autonomic dysfunction when 1 heart rate test was abnormal and 2 heart rate tests were borderline. And definite autonomic dysfunction when 2 heart rate tests were abnormal, and severe autonomic dysfunction when 2 heart rate tests were abnormal plus 1 or both blood pressure tests were abnormal. So anesthesia was provided as per institutional protocol. After surgery, all patients were shifted to ICU and were put on elective mechanical ventilation for 8 to 10 hours and extubated after meeting extubation criteria. Data points were collected in hemodynamic parameters were recorded at baseline and there every 30 minutes till the end of the surgery. Total vasopressor requirement, both dose and duration in intraoperative and postoperative period. Peak noradrenaline and vasopressin dose was noted. Duration of mechanical ventilation, graft function, length of ICU and hospital stay, and 28-day mortality were noted. Statistical analysis, descriptive statistics were presented in the form of mean and median for continuous variable and frequency and percentage for categorical variables. The association between 2 category variables were explored by chi-square test and Fisher test. The association between variable where one is continuous and one is categorical was explored using independent t-test and one-way ANOVA. And where data is non-normal, Mann-Whitney test was used. So stroke chart for our research, we assessed 119 patients for eligibility but only 64 patients were included in study because we have to exclude the patient with diabetic mellitus and our severe patient who has more chance to have autonomic dysfunction were unable to perform these 5 tests. So all 64 patients were evaluated for autonomic dysfunction, and based on the result, they have categorized in 2 groups: Group A with autonomic dysfunction and Group B autonomic non-presence of autonomic dysfunction, and they follow up for 28 days. So result, a total of 64 subjects with CLD undergoing liver transplants were enrolled in final analysis. So our primary objective was to find out the prevalence of autonomic dysfunction. So our prevalence was 40.6%. Based on the autonomic function testing, in autonomic dysfunction, number were 26 out of 64, which came 40%, and non-autonomic dysfunction, 38 out of 64, which came 59.4%. And demographic parameters, they were comparable. Both groups were comparable in terms of age, sex, BMI, etiology, and child class. But we can see group with autonomic dysfunction have higher mean MELD score, which is significant. On the basis, etiological based distribution of autonomic dysfunction, we found that non-alcoholic liver disease, related liver disease constituted largest population of 50%, followed by alcohol-related liver disease, which is 26.9%. Intraoperative variables, blood loss, cold ischemia time, warm ischemia time, GRWR, duration of surgery, total inotrope dose were comparable. A significantly peak NORAD was required in autonomic dysfunction group. Talking about intraoperative hemodynamics, we observed that patients with autonomic dysfunction have baseline resting tachycardia, and during the critical autonomic dysfunction group had post-induction greater decrease in mean arterial pressure. And at the critical phases of surgery, like IVC clamp and reperfusion phase, group AD led to large decrease in mean arterial pressure, which is significant. And there is a difference in heart rate in group AD autonomic dysfunction during reperfusion phase. Now coming to post-operative outcome, in autonomic dysfunction group, duration of weaning of noradrenaline in ICU is significantly higher, and duration of total mechanical ventilation is also significantly higher in autonomic dysfunction group. ICU stay as well, median ICU stay significantly high in autonomic dysfunction group, while hospital stay, ICU readmission and 28-day mortality was not significantly different. So we correlated this autonomic dysfunction grading with MELD score. So there is a good positive correlation between grading of autonomic dysfunction and MELD score, with the correlation coefficient is 0.769, which is significant. Similarly, with as we did for MELD score, we observed a strong positive correlation between severity of autonomic dysfunction and child score. So correlation coefficient is 0.502, and it is significant. So to assess predictive power of autonomic dysfunction for morbidity, which we defined as prolonged ICU stay more than 7 days, autonomic dysfunction is significant in univariate analysis, and we know that MELD and age is already pre-established criteria for morbidity. So we adjusted autonomic dysfunction with age and MELD, and still it is significant for predicting prolonged ICU stay. So we plot ROC curve for to see the as a predictive factor. So when we use only MELD, so area under curve is 0.615. And when we incorporate MELD with grading of autonomic dysfunction, the area under curve improved 0.615 to 0.672. Now, coming to discussion, in this study, the prevalence of autonomic dysfunction was found to be 40%. Among these, early autonomic dysfunction in 10 patients, definite autonomic dysfunction in 9 patients, and severe autonomic dysfunction in 7 patients. So parasympathetic impairment was more prevalent. Deep breathing test, Valsalva ratio, and 30:15 ratio in compared to sympathetic test. We observed statistically significant correlation between autonomic dysfunction and severity of hepatic decompensation in form of, as we saw, the MELD is higher in autonomic dysfunction group, and a higher proportion of autonomic dysfunction was seen in child class C. In perioperatively, autonomic dysfunction group exhibited significantly higher mean baseline heart rate and peak dose of noradrenaline, and they had lower mean arterial pressure during the critical phase of surgery like IVC clamp and immediate reperfusion phase. These physiological impairment translated into significantly longer mean duration of weaning from noradrenaline and significantly prolonged mechanical ventilation and mean ICU stay. So prevalence of autonomic dysfunction is in our studies 40%, while literature report the prevalence of autonomic dysfunction maximum up to 86%. So possible reason that our prevalence is lesser because of we excluded diabetes mellitus and patient with gross ascites, severe pleural effusion, and severe sarcopenia. So severe patient who had more chance to have autonomic dysfunction were unable to perform these tests which I have described. And patient with autonomic dysfunction exhibited increased hemodynamic stability, as we discussed that they have higher mean baseline heart rate and higher peak dose of noradrenaline, greater fall in mean arterial pressure during the IVC clamp and immediate reperfusion. So Perez et al. Also observed that autonomic dysfunction group had more frequent hypotension during neohepatic period and required high dose of noradrenaline after graft perfusion. Similarly, in other surgery than liver transplant, in case of even diabetic autonomic neuropathy, Olderman and Burgess found that refractive intraoperative hypertension and blunted heart rate response after both anesthetic induction and surgical maneuvers. In patient with autonomic dysfunction, prolonged infusion of noradrenaline was required in postoperative period. This hemodynamic lag likely stems from a state of physiological frailty due to blunted autonomic response. So the reason could be impaired baroreflex sensitivity, impaired regulation of heart rate and vascular tone in response to blood pressure changes, and downregulation of adenoreceptor. Chronic exposure to high endogenous level of norepinephrine in cirrhotic patient can lead to receptor desensitization. This delayed weaning from inotrope could be one of the reasons for prolonged duration of mechanical ventilation. Consequently, the median ICU stay were also significantly prolonged in autonomic dysfunction group because autonomic dysfunction would not only affect the cardiovascular system, it involves multi-system. So gastrointestinal dysfunction can caused by autonomic dysfunction. Autonomic dysfunction is associated with enteric neuropathy, leading to postoperative ileus and delayed gastric empty. This result in feed intolerance and delayed nutritional recovery. Second one is urinary retention. Impaired parasympathetic signaling can cause neurogenic bladder-like symptom, necessitating prolonged urinary catheterization and increased risk of UTI. Autonomic dysfunction causes thermoregulatory impairment. Pseudomotor dysfunction can lead to unexplained postoperative fever, which require extensive and time-consuming diagnostic workup. And we also observed a strong association between autonomic dysfunction severity with liver disease, as we discussed earlier. So Pimentel et al. Also found reduced heart rate variability correlated with child plug class and served as independent predictor of mortality. Bustos et al. Also found significantly worsening of both parasympathetic and sympathetic score once the MELD score was more than 20. So we found that NASH patient had high percentage contributing to autonomic dysfunction. So why NASH is more predominant? Metabolic inflammation in NASH patient, there is metabolic inflammation and insulin resistance, increased amount of TNF alpha, interleukin 6, advanced glycation and product, which promotes microvascular damage to vasa nervorum, small vessels which supplies to nerves. This mechanism is very similar to diabetic autonomic neuropathy. So in CLD patient, even in the absence of diabetes mellitus, this autonomic dysfunction happens. And parasympathetic nerves, as these nerves are had longer pores and end organ ganglia, they are more sensitive to this microvascular damage. So they present as early sign of autonomic dysfunction.
Can you summarize, please?
Yes, sir.
Yeah, just give the summary. Sorry to interrupt you.
Yes, sir. So clinical implication that we have to move towards the including functional assessment like Ewing test or heart rate variation, along with the traditional biochemical test like MELD score. Identifying the hidden frailty like even a patient with moderate MELD score have severe autonomic dysfunction, which can lead to unexpected post-operative complication. So we have to better inform consent give to patient and relatives regarding the recovery timelines and ICU duration. And proactive hemodynamic anticipatory use of vasopressor in autonomic dysfunction positive patient to avoid prolonged hypotension during induction and reperfusion. And we have to target the ICU resources. And graft autonomic dysfunction does not directly affect the graft function, but it affect hemodynamics. So indirectly affect the graft hemodynamics. Limitation of studies that sample size the small cohort of 64 patients statistically significant from primary outcome for the prevalence, but in only 26 patients were autonomic dysfunction positive. So that is very small size to perform subgroup analysis. And patients who were unable to perform the test have omitted from the test, which have more chance of having autonomic dysfunction. Morbidity we defined morbidity as a median ICU stay more than 7 days, while this is a common, it can be influenced by other factor also. We did not follow up patient for reversibility or autonomic dysfunction after transplant, and it is single center study. So every center have its own ICU and noradrenaline weaning criteria, which may limit the generalizability to other center. So future direction is we can try the pre-rehabilitation program. Multi-center studies are required to see if pre-transplant rehab can improve, like tailored physiotherapy or nutritional supplementation, like vitamin B12 deficiency is the reason of autonomic dysfunction. And we have to see the reversibility that after liver transplant, the resolution of autonomic dysfunction. So in conclusion, this study demonstrates that autonomic dysfunction is a highly prevalent condition among liver transplant candidates, affecting 40% of the studied population. Our analysis confirmed the preoperative autonomic dysfunction is statistically significant and independent predictor for postoperative morbidity, especially in terms of prolonged ICU stay and delayed weaning from vasopressors.
Thank you, Nidhi. Very nice and very good topic. The guide, you have any comments?
Yes. Autonomic dysfunction is often overlooked topic among CLD patients. As we have seen, it has a large prevalence and it is often overlooked. There are many cases where we see prolonged vasopressor requirement in the postoperative period, intraoperative period. We see for the causes, but this can be one of the cause which is often overlooked. So we thought to do this study to actually see the prevalence and how it affects. And we've seen that there's a large prevalence and it has an effect on the outcomes, which we often overlook. So if we assess this preoperatively, we can better plan for our patients and we can get a judge about which patients may react how. So it can be a good prognostic marker in CLD patients having autonomic dysfunction. And it is an easy bedside test which can be done routinely.
And we should do for all our patients. I will restrict the comments, Dr. Rastogi, and while we are waiting, is Dr. Kaul there by any chance? Dr. Kaul, neurology colleague. Okay. Thank you, Nidhi. Many more, and thank you, Udit. Very good presentation. Dr. Rastogi is presenting in next few 2, 3, 5 minutes some new things everyone should know. And while he is doing, I want to also say we do not see residents and faculty in attendance in the morning classes. This is seriously noted, and it would reflect in your permission for exams and other things. Very clear. It is a must Monday, Thursday class. Rastogi, sir.
Good morning. In next 5 minutes, I'll just apprise you with some of the developments in medical operations side. As you all know, we have made integrated call center on this foundation day. It was inaugurated. What we have done is we have shifted this call center from a crowded, noisy place to upper basement. So that is the cursor. नहीं कर्सर मूव करना चाहिए हाँ ओके so anyway what we have done is we have given them 5 nice stations where these people are really focusing on calls, and because of this change in scenario their motivation has also changed, and the way they respond to calls have also changed. And the best thing is we have got a beautiful monitoring system there, what kind of call they are responding to, how they are responding, and that has shown Hawthorne effect. And because of that, the quality of all the outcome has increased, the output has increased. And the thing is, which earlier we were saying, like you have got 3-4 months ka waiting and all, sir, yahan ye nahi ho sakta. All those things have changed. Now they are very, very receptive, and they are working with this ethos that every call that reaches ILBS belongs to us. And, they take responsibility. They are not palming off. They make sure that the call is addressed in the correct way and it reaches the person who actually will respond to it. Similarly, that every voice carries fear, hope, urgency, or pain. So they listen with respect, they respond with care, and they act with responsibility, because every call we answer, then the ILBS begins. So that is how this call center is working. This has got facility of even virtual OPD as well as liver GAN at the moment. So once we started monitoring the calls, we realized that the number of calls which were coming to us were for appointments. And every time we were saying, sorry, we are booked for next 2 months, 3 months, like this. So there was a need. So we made indigenously ILBS appointment waitlist and online triaging system, which is operational right now. And Dr. Shantanu, along with this call center team, has worked very hard on it. So basically, once we realized that there was long waiting, too many walk-ins, many complaints were regarding that ILBS OPD mein appointment milna bahut mushkil hai, and we were losing patients. There were loss of patient satisfaction also, because appointments were booked only for 3 to 4 months in advance. We were getting only the cold cases or follow-up cases. We were not getting new or acute cases which required attention, like second opinion. They have to undergo transplant somewhere. They just wanted second opinion, etc. Such cases were being missed. So result was overcrowding of appointment list with cold patients, and there was no provision for wait listing. So what we adopted was that, like in railways, they have reservation against cancellation. Similarly, we adopted this feature. We in this, we did triaging. Means solution should have good triaging. It should have ease of booking, that, anybody, even from website, they can reach us. And from call center, nobody should say no. They can accommodate in wait list. And caller, it can cater to no-shows. What happens is when we book appointment 3 to 4 months in advance, 10 to 15%, they tend to forego their appointments. Either they have, they have gone to some other center or for some other reason. And, we have to follow these patients at least 48 hours in advance. At number of telephone calls were being made by these people. So there were a lot of wastage. So we can, those people who are not coming, all those appointments we are giving to other people. So by deliberate and controlled overbooking. So what we have developed is, it is very fast and smooth, hassle-free online system. and it is giving better overall experience for patients. There is no more, sorry, sir, we are fully booked. It is always, sure, sir, may I book your wait list for tomorrow or next week? So the result has been during past 25 days or so, there were more than 2,000 patient requests. There are two ways for patients to reach us. One is through website, other is the call center executive can book a waitlist appointment. And more than 300 patients out of these have been tried with the help of CMO, senior nurses, and Dr. Shantanu. And about 350 new confirmed appointments have been given from these people who have approached us through this modality. So more and more patients are being added every day. So this, if we see our website analysis in this, during past 1 month, 45,488 times it has been hit, out of which the hits where patient is or somebody is interacting with the website is maximum 10% for this page, which facility which we have given. So that means, we don't need any marketing. Everybody is trying to approach us for various appointments. And this is the link. If we click this link, it takes us to the booking thing very easily. Slow internet chalega.
So can you say that the patient who comes today can get an appointment on the same day? This was a problem even for young consultant. They say booking is 2 months. So now how will you accommodate a patient who comes?
Sir, as like once we do triaging and we come to know that, yes, this patient is quite serious, somehow or the other, we accommodate that patient on the same day against this thing. And at times we are requesting the consultant also to accommodate the number.
Sometimes if there is no appointment, even then walk-ins should be seen by somebody. Nobody should go back. That should be the philosophy. And the room that Dr. Rastogi has shown in the first slide, I think it's a very good room. It has 5 cubicles. I went personally and saw there is a TV screen which shows you call waiting. They will call back. Suppose somebody has called and you can't attend, the number will stay there and you will call back and say, okay, sir, calling from ILBS, you called up, we are going to help. And we are trying to improve. आप क्या बता रहे हो?
Sir, this kind of format opens and the patient can put in all the detail. Even our call center executive, they can also enter all the details, and accordingly, in this app you can see so many patients we are accommodating like this. All the details are there and everything has been made through this app only, sir. And no external support has been taken.
So
it is
we can
only
take everyone for a small round to the fair,
Yes, sir.
and then there is a liver gyan, which is 9 o'clock to 5 o'clock. There will be a nurse and a junior consultant all the time. Any patient anywhere calls up, sir, मेरे को jaundice है, sir, मेरे को क्या दवाई लेनी है. There will be somebody who will be answering all these things, and we are in the process of improvement. So please give your suggestions if any.
this
Can I
Yeah,
suggest? Sir?
yeah
I just want to, I'm very curious how triage is done.
triage, like based
How
on
we are doing
See,
the triage.
I'll tell you how we are doing triages in this modality. Unfortunately, because of net issue, I am not able to show. It needs more time. Patient is given opportunity to put in his symptoms, his investigations, and what all treatment he has taken already. So in that, once we come to know that, yes, this is there, that is how we are giving triaging.
Okay, so if supposing somebody says obstructive jaundice, okay, ultrasound obstructive jaundice. So how that patient will just read out. And I suppose the one who is sitting on your call center, does he understand obstructive jaundice? Who will see obstructive jaundice?
It is not, triaging is not done by call center executive. It is, all those calls which are like this, our team analyzes them with the help of CMO and
So
experience.
that's what I'm asking. I'm asking very plain, simple question. Obstructive jaundice, a patient calls and says, ultrasound is saying obstructive jaundice.
Yeah.
I need an appointment, right? So how this appointment will be sorted out for you?
So we'll give him priority. Sir,
So how it will be done? Because to my understanding, there are many OPDs which are running empty, and there are many OPDs which are running on appointment of 3 to 4 months. So that's where, because many patients are being tracked into OPDs where they should not be going first. So that's a one point, because I'm telling you in the best interest of the institute, because if you take if you're just tracking patient into one direction, this is how you lose out on patient. There are many patients like gallstone.
Yes,
patients,
listen
they're
to
being
him.
tracked.
Yes, listen to him.
Which we had worked on. And you said that important thing not able to reach us. So what we did was we gave the patient an opportunity, and Dr. Serene also for many times mentioned that the patient should have an opportunity to upload my story. What is the story of the patient? We don't have the story of the patient. Only the call center executive was talking to them, and they were making appointments based on their best judgment, which obviously cannot be the best judgment for a patient who wants to visit us. So what we did was we gave them an opportunity. Here the patient gets an email. They can upload their reports also. So they are not just patient, they can upload their symptoms, they can upload their side, what they are doing, if they are getting treatment in any other hospital. Everything they say over here, like here this patient has said, this is a patient of. So the patient has reported that they have jaundice, yellowing of eyes or skin, weight loss of appetite. I was complaining loss of appetite and losing body weight. I have a medical history of hypothyroidism. So these things are
How do you
by the
adjust?
CFO or the doctor.
Chandanu, I agree with the point you made, but try and understand my point as well. You're trying to do this. How you're auditing, because what is happening is what we are seeing is there are lots of OPDs which are running empty. And then like
I would
objective jaundice
suggest,
patient,
in the interest of time, you ask Dr. Pamecha, sit
sir.
and further improve. This is just 2 weeks or 3 weeks of work. And now a CMO, not a call center guy, will attend. Everyone can
Please stay
write
on,
my
please stay on. Please don't leave. 2 minutes, please don't leave. There
Okay.
is some other thing also.
quickly. We are running late already. Should we do it next Monday or so?
Okay, sir, but we'll need 15 minutes or so.
15 minutes, okay, operations. But come with quick,
Yes, sir.
this.
I'll bring.
All right, thank you.